Our topic here is acute disseminated encephalomyelitis. So what does this mean to you? If you take a look at the picture here, we're affecting the spinal cord and we're affecting the parenchyma as well of the brain. It's a monophasic demyelinating disease that most commonly will be following a viral infection or a patient has received immunization. That's important. It's called acute disseminated encephalomyelitis. Please look for a viral infection and then following which may result in a demyelinating disease. Symptoms develop a week or two after the antecedent infection. Diffuse brain involvement, headache, lethargy, coma in some cases. Prognosis, well here recovery typically near complete, thank goodness, because here for the most part, as long as you're able to properly provide supportive therapy for the viral infection, then perhaps this particular issue goes away. Okay, less than 1/3, however, will go on to multiple sclerosis in the future, so keep that in mind as well. You want to think of this as being perhaps something like pre-multiple sclerosis, if that helps you. This one's important. Pay attention to ADE, viral infection. This is transverse myelitis. I'll give you one clinical pearl. Stay away from the brain in this condition, okay? The reason I say that, if you say myelo, you'll notice there's no encephalo. In addition, take a look at the schematic here. There's no brain pictured here on purpose. So it's a demyelinating event restricted to the spinal cord. Way back when we talked about spinal cord pathology, or when you have reviewed it, we talked about transverse myelitis as being a possible cause of trauma to the spinal cord. Here you have it. There's no evidence of brain lesion. That is the absolute clinical pearl that you want to take out of this. Can be in isolation or associated with autoimmune disorders such as Sjogren. You have your LA, right? What am I talking about? Your SSA, Rho and LA. SSA is going to be your Rho, whereas SSB will be your LA. Extremely important when you do autoimmune diseases. With Sjogren, treated with steroids and plasmapheresis. Why? Because you're thinking about autoimmune diseases and can be recurrent. This is called transverse myelitis. Look for autoimmune diseases. For the most part, inflammation of the spinal cord with no involvement of the brain. Our next topic, your patient comes in and, was taking carbamazepine. Why? Oh, to treat perhaps trigeminal neuralgia. As a side effect, we get labs. And on the labs, it shows that your sodium levels is 125. Would you please put together carbamazepine and sodium level that is what? Decreased. Hyponatremia. That's your patient. It's coming in with hyponatremia. You want to correct this. Huh? You want to correct this. Unbeknownst to the resident, unbeknownst to the intern. Get all anxious and extremely happy and wanted to correct this, and so therefore too rapidly corrects the hyponatremia. And in the process results in a condition called central Pontine myelinosis or myelinolysis. What's happening? Allow the name to speak to you. The pons, you're in the brainstem. What's happening in the central portion of the pons, if you take a look at the picture here, it clearly tells you what's happening. The lesion is in the central portion of the pons. What's happening? Demyelination. Why? Well, there are many theories out there at this point. What you're correcting for too rapidly was the hyponatremia. So what was I trying to say with carbamazepine? Carbamazepine causes a side effect of SADH, syndrome of inappropriate antidiuretic hormone. With too much ADH, what then happens to your sodium levels? Hyponatremia. And if you want to correct it too quickly, there's every possibility that the patient may suffer from central Pontine myelinosis. That's unfortunate. This whole thing could have been prevented. And really, the next step of management was to take the patient off the carbamazepine in this particular case. It could be also seen with alcoholics. Anything that causes hyponatremia, and there's rapid correction. It is the basis pontis classically, but could be other sites as well. Keep that in mind. Never, never correct your hyponatremia too rapidly. Presents with, look at this. Look at the manifestations. It's devastating. It's tetraplegia, quadriplegia. The patient loses all ability to move. I'm locked in. Isn't that a horrible feeling? You have all your limbs, you're completely aware, but yet you can't move anything. Could you imagine how the patient is going to feel? Because not you, but someone that you know rapidly corrected the hyponatremia. Common presentation. What are you going to find? Acute paralysis, maybe dysarthria, difficulty with speaking, and dysphagia. You're knocked out the brainstem. Holy cow, no joke. What happened? Don't correct the serum sodium to more than 10 units per 24 hours. Clear? Memorize that. Memorize that. And only then are you permitted to move on